G'day from sunny Sydney, Australia. My name's Aidan. I'm a paramedic researcher and medical student. It's actually raining at the moment, so hello from rainy Sydney, Australia. Today I'm going to be talking about pre-hospital ultrasound. And I just want to start off by acknowledging the traditional custodians of this land I'm speaking to you from. I'm speaking to you from the lands of the Gadigal people of the Eora Nation. Gadi means grass, and so the people of the grass. Aboriginal people have been the custodians of this land for 60,000 years. They're the oldest living continuous culture on Earth, and this land always has and always will be Aboriginal land. So I'm going to be talking about pre-hospital ultrasound today, and it was supposed to be cases from the outback, and you were going to hear about me, the crazy Australian paramedic who goes off into the middle of nowhere with his trusty ultrasound and makes these miraculous saves and whatnot. But that doesn't actually make the case that I'm hoping to make today. This is a map of Australia. I've superimposed Ireland in the middle of it. Apologies, I've taken a bit of liberty with the dimensions. I actually made Ireland a little bit bigger. The green dot is Sydney, and the red dot is one of the places, of a few places, that I had the privilege of working as a paramedic at mass gatherings and folk festivals and rural clinics. It's very easy to justify ultrasound and pre-hospital ultrasound when you're in the middle of nowhere. It's not going to help to make the case for pre-hospital ultrasound if that's all I talk to you about. So I'm actually going to focus on the use of ultrasound in the pre-hospital arena within 20 minutes of the closest hospital. And that's kind of what I'd like you to have in mind today. If you happen to be interested in more remote kind of field cases, this is a case study which I'm really proud of, and thank you to Jerry Byrne and Anthony Walls, my sonography supervisors. This is the first descriptive case series of point of care ultrasounds in community and kind of extended care paramedicine. So have a look at the QR code, and it'll be at the end of the talk as well if you'd like to have a look at that. But anyway, on with the talk. When we talk about ultrasound and pre-hospital ultrasound, it's really important that we establish a few foundational values and truths. The first is that the majority of care is going to be delivered by paramedics. I'm speaking to an audience of multiple different healthcare professionals, but it's an emergency medicine conference and a lot of you are going to be emergency physicians. And so the question, I guess, is what is the role of physicians? And I would put to you that the role of the physician is to be the custodian of medical knowledge and expertise, and to be the enabler of a system of care to deliver the right care to the right patient. And so I would urge you to be advocates and empower the clinicians you work with to deliver appropriate care and the best care possible. And I'm going to suggest to you that pre-hospital ultrasound is part of that system and package of care. The second thing I'm going to say is that I'm not particularly interested in doing things which don't change care and don't change interventions. And so what I mean by that is, if I'm a paramedic and I have a trauma patient and I happen to scan their abdomen and I find free fluid in Morrison's pouch, me, as the ultrasound nerd I am, gets very excited. I froth over the fact that I can see a tip of the liver free floating in intraperitoneal fluid. I get very excited. However, that patient is going to go in an ambulance to an emergency department, into a CT scanner, back to a resus bay, and probably up to theatres. And if, let's say, I was in a helicopter and I had some packed red blood cells and FFP with me, the fact that there's free fluid in the abdomen does not change whether that patient is going to get a transfusion or not. The decision to transfuse is a clinical one based on signs of shock. So I'm wholly disinterested in things which don't change what I do, and one of those things is the abdominal component of the EFAST. And lastly, if we're going to change what we do, we need to be measuring it. And we need to make sure that the outcomes we're measuring are important outcomes to patients. And that is probably the most key, crucial, critical thing that I can advocate for. It has to come back to patient outcomes. So let's get cracking. Just to reorient ourselves, this is the chest. We're going to pop the ultrasound on the chest, and I'm going to introduce you to 2 ribs and a pleura in between them, and some beautiful fuzzy whiteness of the lungs, and that gorgeous pleura which sparkles whenever we hit it with lung ultrasound. We have a 35-year-old male who's had a bit too much to drink and wandered into a dark street and been hit by a car at 40 miles an hour. Paramedics arrive. The patient has bruising and tenderness on his anterior and lateral chest. He's dyspneic. He's tachypneic. He's a bit hypotensive because of the trauma. It's probably reasonable that those paramedics are going to go and say, this patient has a pneumothorax. They're going down, let's decompress. Unfortunately, this is a plumb normal ultrasound. That decompression could have been avoided if we had done this ultrasound. It was a harmful intervention which wasn't going to affect that patient positively. And there's the pleura. On the other hand, if we take a different patient and put some air into that chest wall between those 2 pleura, that exact same clinical presentation of dyspnea, tachypnea, hypotension, tachycardia, anterior and lateral chest wall bruising and tenderness, this time with a pneumothorax. There we've got the rib, we've got some intercostal muscle, and you can see it retracting as that patient tries to breathe, and the beautiful white line of the pleura. This is a classic pneumothorax. Now you take that exact same patient, you've got a lung ultrasound finding of pneumothorax, and you are good to go to stick a needle in the chest and decompress it, because the patient has clinical signs of tension. So already we can see that lung ultrasound makes us safer by avoiding harmful and inappropriate interventions and allowing us to do safely the appropriate intervention. Now, let's say that same patient is being treated by a critical care team out of hospital. You've got a senior paramedic, and that paramedic is about to load that patient into a helicopter. And they move just down to the kind of right upper quadrant above the diaphragm. That's a normal right upper quadrant lower lung ultrasound. You've got liver, you've got diaphragm, and you've also got some spinous processes at the back of the ultrasound there. Now, you take that exact same patient and you put this ultrasound in. This is the spine sign. You've got that fluid above the diaphragm, so you can see through the chest, you can see those spinous processes which are continuing past the separation of the diaphragm from the posterior wall. This patient has a pleural effusion, which in this exact patient is actually hemothorax. If you know this, it changes what you do, because you know that this patient who had a needle decompression and is not getting any better is going to make a lot of mess when you stick a finger in for a finger thoracostomy. Your pilot, if you're in an aircraft, is going to be very displeased with you. They did not ask for the internal decoration. It also means that if you're a paramedic close to a local emergency department, but not a major trauma center, you can duck in, get an intercostal catheter placed, and keep going to your major trauma center. This changes how we manage patients. However, trauma patients are a minority. They are not the majority of the patients we see. So instead, I'd like to introduce you to a much more common patient. Let's talk about dyspnea. And particularly, let's talk about dyspnea in a patient in their 70s with a history of COPD, hypotension, and diabetes. A paramedic comes to this patient who's dyspneic, slightly hypoxemic, and maybe mildly hypotensive. They have, let's say, a few crackles on auscultation. COPD, hypotension, diabetes, crackles, dyspnea, mildly softer blood pressure. This is a classic story for pneumonia on a background of COPD. However, when we scan this patient's lungs, their pleura are pristine and there's B lines everywhere. This is cardiogenic pulmonary edema. This is cardiogenic pulmonary edema. The last thing this patient needs is fluids, antibiotics, and steroids. This patient needs CPAP nitrates and furosemide. Lung ultrasound has stopped us doing something that could potentially be harmful and unhelpful to this patient. And the interesting thing is, this is a great study from New Zealand where they compared paramedic versus ED consultant diagnosis of dyspneic patients, and they found that the kappa was 64%, the agreement was 64%. I personally think that's pretty impressive considering paramedics were stuck in a box on the side of the road without chest x-ray and bloods. It makes sense though when you have a look at this. We did this study in the Netherlands, in Groningen, with the simple intensive care study. And we took 926 patients in the ICU. And we took a medical student who did a comprehensive physical exam and another medical student who did a comprehensive point of care ultrasound. And what we did was we found that 307 of those patients had clinically significant pulmonary edema diagnosed by lung ultrasound. And the medical student who was blinded, who was doing the physical exam, found completely normal lungs on auscultation in 51% of those patients with pulmonary edema. These medical students were final year, and they were assessed as competent by a bunch of physicians at performing a standardized physical exam. The stethoscope is not the be-all and end-all of our diagnostic and clinical acumen, and we would really suggest that when it comes to pulmonary edema and pulmonary pathology, the ultrasound is far more accurate. And so you then take that same patient with COPD and hypertension, and you scan their lungs and you find this yucky pleura. It's heterogeneous, there's small consolidations underneath, and you find B lines throughout the ultrasound. You go, okay, this is classic. This is classic pneumonia. You've got B lines, you've got effusions, you've got gunk and consolidations. This patient needs fluids, they need antibiotics, they don't need nitrates, they don't need CPAP, and they certainly probably don't need furosemide yet. What if we take the same COPD patient and we hear a wheeze on auscultation, and they're a bit tachypneic and a bit tachycardic, and for some reason the paramedic goes, you know what, I'm going to scan the veins. And they scan the proximal femoral vein and they find this non-compressible proximal femoral vein. This is a DVT. Who here wants to give this patient salbutamol for their COPD exacerbation? Exactly. Who here wants to give this patient an aspirin, hold off on the beta agonist, and call ahead to the emergency department to get the CT scan ready? Paramedics are called to a 50-year-old male at the local shopping centre who's had a syncopal episode. They get there. The patient is very, very anxious, a little bit tachypneic, a little bit tachycardic, and quite hypotensive. But besides the anxiety, normal history, no comorbidities, and the paramedics cannot find anything. The paramedic in question decides that they're going to do a rapid ultrasound for shock and hypotension, and they do a focused cardiac ultrasound and they find this. The right ventricle is significantly dilated and bigger than the left ventricle. In and of itself, this is not diagnostic of anything, it's just right ventricular strain. However, they also then go and scan the proximal femoral veins, and they see this big clot in the proximal femoral vein, and 30 seconds later, this patient loses pulses and goes into out-of-hospital cardiac arrest. RV strain, large proximal femoral vein clot, anxiety, tachypnea, tachycardia, hypotension, and out-of-hospital cardiac arrest. Who here thinks it's unreasonable for the paramedic standing there to give tissue plasminogen activators, to push some TPA, with that objective evidence? I'm very proud to say that I have a colleague who's a critical care paramedic up in Queensland who had almost this exact same case with a young female who had out-of-hospital cardiac arrest, and he took the tenecteplase, which was intended for STEMI thrombolysis in the field, and he called his medical director and he pushed that TPA, and that female patient is now completely neurologically intact, walking around in the community. And finally, you're a paramedic at 9 p.m. who's called to an 82-year-old patient at a nursing home with dementia, who's just a bit off today and has some diffuse abdominal pain. And you do a cursory abdominal ultrasound and you find this loop of bowel. It's small bowel, it should be less than 3 centimeters. This is 5 centimeters, it's dilated, and there's a to and fro appearance to its contents. This is a small bowel obstruction. If you think about the normal journey of an 82-year-old with dementia, with maybe a bit of abdominal pain who's off, according to the nursing home nurses, they get taken low priority to triage. They get triaged to a bed. Maybe after a while, they sit in the bed for a long time. A junior comes and assesses them. Eventually, they get some bloods done. And hours later, they get a CT scan, by which time their lactate is increased, their blood pressure has decreased, and they are starting to manifest end organ disease. How many patients could we save every year potentially if we could pick up on pathologies like this in the elderly before they started to have physiologic compromise? Pre-hospital ultrasound shifts the locus of care to the patient. That's the message I'd like to leave you with today. Thank you so much. Thank you all. Thank you to the organizers, and I hope you have a wonderful remainder of the conference. Bye for now.